Dear ISSUP members, welcome to the webinar Quality in Treatment. The webinar is jointly hosted by the Quality in Treatment Network and the new UK ISSUP National Chapter. We've got a great lineup of speakers for you. We're having a couple of internet issues, but hopefully that won't stop us, and most of us are online and ready to talk. And the speaker's going to talk about this topic, quality and the workforce, from different perspectives. Now, we had just under 900 people sign up for the webinar from 92 different countries, which is fantastic. So clearly there's a really good interest in this area. If you've got questions at all, please put the questions in chat. There's time at the end. We'll filter some of the questions and then field some of them to the panel. So welcome, and you can see we've got a great lineup. We've got all the presenters there on this slide, so you can see us. So let me just say quickly what we're going to be covering and who's going to be speaking. We've got an introduction to ISSUP, and we've got Joanna Travis-Roberts speaking, the Chief Exec of ISSUP, and we've asked Joanna specifically to do this because there's not very many ISSUP members yet in the UK. So we're trying to encourage people from the UK to join. We then got a talk on workforce issues in terms of quality and international guidelines, but then with a focus on England. And it's really a story of what we've done wrong and what we could do a bit better and how international initiatives could help. We've got a speaker, Ben Parker, who's going to be talking on the role of staff with lived experience of substance use disorders and treatment. We've then got Professor Carmel Clancy talking about the role of nurses in substance use disorder treatment, and that's also from the perspective of the international nurses for the Society on Addiction. We've then got a dual act, a double act from fabulous colleagues from Scotland, Angel Shek and Tracey Clusker, who are going to be talking about some initiatives in Scotland in terms of mapping the workforce and then trying to implement some new standards for medication-assisted treatment. So we hope you're going to enjoy the webinar, and I'd like to hand over to our first speaker. So Joanna, would you like to take the floor? Thank you.
Thank you, Annette. So first of all, I just want to say thank you to Annette, our host, for organising this excellent session, working with us to bring this topic to ISSUP members and to the people that are tuned in today who are not ISSUP members and are listening in. It's an excellent, interesting one, so I think you're all going to enjoy it. As Annette said, I'm going to tell you a little bit about ISSUP. ISSUP is the International Society of Substance Use Professionals. We're an international membership organisation really focused on development, support, networking, and really the representation of this workforce within prevention, treatment, and recovery support. We're really delighted. We have over 20,000 members all around the world. So we have a strong network out there. Our work is supported by the US State Department, INL, and we enjoy excellent working relationships with lots of other agencies, such as the quality and treatment work that Annette is leading on. And we like to bring and sort of signpost our members to the resources, the learning, the opportunities really that are available via our partners. ISSUP's vision is a connected, trained, knowledgeable and effective international network of substance use prevention, treatment and recovery professionals who are undertaking and promoting high quality, evidence-based and ethical substance use prevention, treatment and recovery support. And I just always want to reinforce that when we consider this network, when we consider the people out there on the ground doing the work, we include all elements within that. So that's volunteers, family members, all the way through the spectrum, the people that have studied and made this their lifetime career, that are doing it full time. So we really want to consider all of those elements within the field and ensure that they all consider themselves as the vital piece of the workforce that they are. We deliver this mission and sort of work towards this vision in 3 ways. So digital, which is through all of the things that we have online, all of the resources, the tools, the website, the social media, all of the things that you will find online about ISSUP. Our events, so it includes ones like this, in-person events, signposting people through to trainings that are available, and our national chapters, which is where we work with a host organisation in a country, and that really allows us to deliver our mission on the ground within that more relevant local context and to work with what the workforce might need within that country. We have a short animation which does a much better job of talking about ISSUP than me, so if we can just play that now, and then I'll come back and introduce the rest of the webinar.
ISSUP is an international professional society that connects, unites, and shares knowledge across the global prevention, treatment and recovery workforce. Substance and drug use disorder are major global problems. There is enormous unmet need for effective prevention, treatment and recovery support worldwide. Across the world, clinicians, service managers, public health specialists, researchers, volunteers, families, communities and civil society are working hard to help save, support and improve lives through well-organized, effective and ethical systems and services. Evidence-based prevention, treatment and recovery programs and strategies offer huge benefits for individuals, communities and society. However, there are many challenges and obstacles that stand in the way of providing effective practice. ISSUP is here to help. We connect. ISSUP members are plugged into a thriving professional network for sharing practical advice and knowledge across a wide range of themes and specializations. Our online community allows you to communicate with other members and share ideas, research and resources. Our national chapters connect you with peers in your own country and bring national focus and context. ISSUP links you with our partner organizations, developing training or supporting policy making. And we can connect you with a network of universities delivering, developing, and promoting academic education within this field. We unite. Gain inspiration from your peers, learn and share ideas. Join online and in-person events taking place around the world. Access a wide range of online learning and training resources, including courses for the Universal Prevention, Treatment and Recovery curricula. We can also help you gain internationally recognized certification and credentials through our partners, offering you the chance to verify and share your achievements. We empower the field. We break down the walls that exist between research, policy, and practice by promoting the exchange of knowledge and speeding up the transfer of knowledge into practice to improve health, education, and economic outcomes for people and communities. Join us today for free by visiting our website and discover the benefits of ISSUP.
Thank you for playing that, Olivia. So that gives you an idea of some of the resources and tools that we really have for the workforce. As I mentioned, and as the animation said, we have national chapters, and we are really excited to be launching ISSUP in the UK on September the 23rd. So we've been working, with ISSUP UK, and this is really their event to sort of announce themselves and give a little bit of input. So they're having that launch. It's going to be focusing on supporting families. So I really encourage you all to go to the website and have a little look to register for that event on September the 23rd. We're very excited to be working with the fantastic network that ISSUP UK has, and the board members, some of which are on your panel today. So I'm just going to do a little bit of housekeeping. Everybody who is attending today will be receiving a certificate of participation. We're recording this session, and that will be available on the ISSUP website in the next couple of days. please put your questions in the chat, in the questions box, and we will collate those and have a Q&A session at the end. We often receive many questions and we can't obviously get through them all. So if there are some unanswered ones, then we will put them on the ISSUP website in an online forum called the Quality in Treatment Network, and we'll pop a link to that in the chat as well. So you can always go afterwards, and the recording from this will be in that network. There'll be a discussion if there's any unanswered questions. So that would be a really great place to see if there's any follow-up information after this. And just leaves me to say thank you very much again to our excellent panel, to Annette for moderating and bringing the group together, and to you for joining to listen in to today's session. It's going to be a good one. Thank you.
Thank you so much, Joanna. That was fantastic, and that was just what we needed to hear from ISSUP. And if there are people that are listening to the webinar that are not ISSUP members, I'd really encourage you to join. I think it would be fantastic if you did. It's a great resource for us all. Okay, so what I'd like to do now is start the next presentation. So this is my presentation, and it's on workforce issues in England. I'm just trying to share my screen.
Unmuted.
I may need to, Olivia, can you just ask me to do that again, please? I don't think it's worked the first time. That's great. Okay, sorry about this. Okay. Please let me know if you can see this.
Yes, we can see.
You can see? Great. Is the control panel showing as well?
No, it's not showing.
Okay, great. Fantastic. Okay. So I'd like to speak with you about workforce issues in England and some of the international initiatives that can help England, but also everybody else. My disclosures are up there. So I've got current international consultancy contracts for the United Nations Office on Drugs and Crime and Colombo Plan, and I'm a visiting academic at Middlesex University and a trustee of the charity Build on Belief, and I'm also on the Treatment Expert Advisory Group for the Universal Curricula. Okay, so I'd like to briefly cover in my talk the relationship of workforce to quality in drug use disorder treatment, some key issues in England. And you might think, oh, that's not going to be relevant for us because England is a very high income country, etc. But as I say, it's really slightly a story around what we've done right and what we've done not quite so well. So and I think that there's learning for us all in that kind of a story. And then briefly some international initiatives on quality and workforce development that could help. So first off, I'd like to talk to you about the relationship of the workforce to quality in drug use disorder treatment. Now, I'm sure that you're all aware that staff are critical to quality in drug treatment and also to achieving outcomes for our patients or service users. And there's very strong research evidence from multiple studies over many years that show that staff competence and attitude is critical to service user outcomes. Now, this includes things like the staff ability to provide evidence-based interventions, to form and maintain therapeutic relationships that are so important to the basis of treatment, to be non-judgmental, compassionate and caring, and to be able to motivate and retain patients or service users in treatment. And in fact, there's research that shows that the motivational ability of staff actually has much more influence on some outcome measures than that initial motivation of patients or service users that can fluctuate wildly. Now, staff are the biggest cost in treatment services normally. They're our biggest asset, and yet they require ongoing investment. Okay, now we've got some great international guidance at the moment that can really help prioritize drug use disorder treatment and expanding drug use disorder treatment, and then also some good guidance on how that should be provided, both in terms of services and system. I'm sure you're aware that it's a global priority to expand drug use disorder treatment and alcohol treatment, in fact. And so there's a call for all UN member states to consider expanding the coverage of treatment and also pay attention to the quality of treatment systems and services. So that's the UN Sustainable Growth Target 3.5. And on the left there, we've also got this key international guidance document. If you've listened to any of the quality and treatment webinars before, you'll know that we talk about this guidance all the time. So this is guidance, the international standards on the treatment of drug use disorders, and it really is good evidence-based guidance on how to provide ethical, evidence-based treatment for services and systems, no matter what country you are in. Okay, now in this international guidance, the international standards for the treatment of drug use disorders, there is some specific reference to the workforce. And I've just pulled out 4 specific things here. And the standards say that staff working in specialised services should be adequately qualified and receive ongoing evidence-based training, certification, support and clinical supervision. That staff should receive training in the delivery of treatment in full compliance with ethical standards and human rights principles, and show respectful, non-stigmatizing and non-discriminatory attitudes towards service users. And we know this is really, really critical, and sadly a lot of our service users do experience stigma and discrimination, including sometimes from staff in services. Staff should also receive clinical supervision, mentoring, safety protection measures and other forms of support. And that's also to prevent burnout. Burnout is a really common thing in our field. So we need to protect staff against burnout. And then finally, the training of all health professionals. So this is in things like primary care and other forms of specialist care. Should include the identification, diagnosis and evidence-based treatment for drug use disorders. And ideally, this should be in place at different levels in education, including university curricula and also programs of continuing education. Okay. So in summary, some of the workforce good practice requirements, there's essentially 2 sides to this. So we've got the drug treatment service workforce here, and I'm talking here about the specialist workforce as well. So there's 2 elements. Firstly is that staff are competent and supported, and secondly is that ideally we should be working in a multidisciplinary approach, either within services or within a local system. Let's have a look at what this looks like a little bit more. So let's expand on this. So on this side, so in terms of staff being competent and supported, staff should have the knowledge, skills and experience to practice, and ideally should have qualifications and professional registration. Staff should have continuous professional development, or CPD, including training. I think it's really important to state here that one-off training is not enough. And the value that you get from training can be quickly lost if it isn't backed up by the continuing professional development, the support, the supervision, etc. So finally, staff should receive supervision, support and management. Okay, and then looking to the other side of the diagram, in terms of a multidisciplinary approach, there's a whole host of different disciplines that are recommended in the international guidance. Everything from psychologists or counsellors, or people providing psychosocial interventions, drugs workers, or sometimes called key workers or care managers or coordinators, nurses that are competent in substance use dependence, doctors, including specialised doctors and also primary care, managers, admin staff and data staff, peer mentors or staff with lived experience, social workers, vocational workers, housing support officers, staff involved in the criminal justice system, pharmacists, etc., etc. Now, you don't always get these in one team, and these people might be spread throughout the system, but that multidisciplinary approach is really, really important. Okay, now let me talk a little bit about England and the story in England. So I've used a kind of an Olympics analogy here, and I think the story, our story, is that we were really in the running to win a gold medal, and then we kind of lost, and quite significantly. So I'd like to do a bit of analysis around what on earth has happened and why. So in England, we were actually doing really well as far as expanding and improving the quality of drug treatment. And we'd been doing really well between 2001 and 2010. Now, note to our international listeners, drug treatment is free to patients in the UK. We pay for it through our tax. Our tax is quite hefty, but it does pay for NHS and all forms of treatment, including drug and alcohol treatment. Now, 2001 to 2010, drug treatment became a political priority in England due to the government. And the government gave a large investment in treatment. And it became a priority because it was realised that actually drug treatment could help combat crime. We had a heroin epidemic in the country in the 90s, and this was driving drug-related crime. And the government realised if they invested in treatment, it would benefit communities, individuals, but it would also drive down crime. So the large government investment meant almost a tripling of the investment. The target was to more than double the numbers in drug treatment. And this actually resulted in falling drug use, falling drug-driven crime, and an increased focus on recovery-orientated treatment, and a recognition of the value of people with lived experience of substance use disorders, people in visible recovery, and mutual aid. So we were doing really well for those 10 or so years. Okay, but then things happened. Okay, we were still having relatively high levels of drug-related deaths, specifically overdose deaths. In England, we have a lot of heroin use, people who use heroin, and people who use heroin and crack cocaine. We'd done this rapid expansion, but it had led to a fragility in our drug treatment workforce because we'd expanded so rapidly. So we'd actually ended up with many unqualified staff in the workforce, particularly at the drug worker or key worker level. And we had relatively weak basic education and training in substance use disorders and treatment. And we had a weak system for qualifications for that basic drug and alcohol worker level. We had some things, but it wasn't strong. Now, we did have some very good workforce initiatives. So we did develop drug and alcohol national occupational standards called DANOS. We did have some good professional workforce networks. So we had a GP network called SNMGP. We had a network for psychiatrists called SCAN. We had a network for drug and alcohol professionals called FEDAP. And we did some big national training initiatives, including national training on rolling out the cognitive mapping techniques as a way of really grounding and rolling out some of the core psychosocial interventions. However, the funders of drug treatment at a local level, they didn't put in the specifications the requirements for qualified drug and alcohol workers at that basic level. And we were also facing a growing critique against the drug treatment sector because we had large numbers on methadone and buprenorphine in opioid medication assisted treatment who were very dependent upon the state, dependent on treatment and in poor health. Okay, we also then had austerity. So then austerity hit us. We then nationally also had a devolution agenda hit. So there was a devolution of power and funding from a national level to local level authorities. So we then had those two things. All right, then fast forward to 2019. And the government recognised things weren't going quite to plan, and so they requested an independent evidence-based review on drugs to inform the drug strategy. Part 1 was published in 2020, Part 2 was published in 2021. And the review, it was brave of the government to do this, but the review was quite damning in many respects. The conclusion of the review was that in the last 5 to 10 years, so 2010 to 2019, all the main indicators of drug use were going in the wrong direction. So there'd been an increase in the use of opioids and cocaine. The use of other drugs had increased after having decreased. Drug-related deaths were at an all-time high. The numbers in drug treatment had reduced, and people had poorer outcomes than they had previously, and there was a big geographic variation. Particularly with people in the north of the country, that's where I'm from, having more drug use and more problems. And this was the areas that had more social deprivation. Okay, so why had our treatment system deteriorated? Why? Well, the big one was we had a significant reduction in funding. We'd had austerity measures come in, and this had really impacted on health and social care systems, including substance use disorder treatment. This had been accelerated by devolution and a move of public health who were responsible for substance use disorder to local authorities away from health. And together with that, there was a loss of a real or perceived ring fence around that money and a loss of accountability over that money. England is known for frequent recommissioning of drug treatment services, and this had resulted in a loss of stability in some systems and a drive to lower and lower costs. I've nicknamed this the English disease. This doesn't happen in other parts of the UK, and this has been perceived as being quite detrimental. And that we'd also lost significantly some types of drug treatment in our local systems, particularly those high-cost, low-volume services, especially our NHS inpatient units and residential rehab beds. And the Black Review concluded that we've got a compromised and demoralised workforce. And the quote there from Dame Carol Black was, "The drug treatment and recovery workforce has deteriorated significantly in quantity, in quality and morale in recent years, with excessive caseloads, decreased training and a lack of clinical supervision." So this is quite damning, actually. So some of the key issues were we've now not got enough qualified staff. We've got drug workers, that basic level workers that lack competence and qualifications, and they've got poor supervision and high caseloads. 10% of volunteers are unpaid. So the services are absolutely reliant on these drug and alcohol workers with minimal or no professional qualifications. Workforce recruitment and retention issues are very prevalent, and some of this is caused by the frequent retendering of services, and we don't have enough formal training placements for the next generation of workers, including psychiatrists, psychologists, nurses and drugs workers. Okay, the Black Review made some solutions related to treatment systems and then some specific solutions related to workforce. So let's take a quick look at these. And essentially, Black recommended that the government faces an unavoidable choice, invest or keep paying the consequences, the negative consequences. A whole system approach is required, with demand reduction a key component, and the focus of the review then focused on some very key concrete proposals to do this. And basically these amounted to more funding, better coordination and better accountability, and addiction being seen as a chronic health condition. And this also included better responses for people with drug problems who were involved in the criminal justice system, including prison through care. Black recommended a reform of local and national leadership and a new government central drugs unit, extra funding, almost double the funding, but importantly ways to protect the funding so it's not lost to mainstream health and social care, and more accountability in the system around funding. Local systems commissioned on at least a 5-year cycle to get some stability back in the system, a rebuilding of the workforce, treatment services and recovery support, increased diversion from criminal justice system, increased efforts to address comorbidity, mental health trauma and physical health problems, and an improvement in housing and employment support. In terms of workforce issues, Dame Carol Black had some specific solutions, and here they are with my comments on that. So she recommended a cross-government workforce strategy that I totally agree with. She recommended clear occupational standards and a training framework for drug workers and peer recovery workers, especially in psychosocial interventions. Now, we've already got some national occupational standards. Perhaps we should update these. And the national training and qualification framework. I think, yes, a national training framework is required, but we need people to have qualifications, as in some countries. Dame Carol Black recommended a new professional body, a centre for addictions, and there was an example that she quoted. Again, it's a great idea, but I think it would be good to have a multidisciplinary body. The body cited was only for doctors, and we've got some of these already in the UK, and perhaps they could join forces into a multidisciplinary body. She recommended that we increase the number of professionally qualified drug treatment staff. Yes, I totally agree, but unless this is required by commissioners, I don't think this is going to happen. State-funded training, yes, but this needs to be prioritised and monitored. And competency requirements for all staff, yes, and try and get this into the basic education and training of all professional groups. Okay, so let's take a quick look about how some international initiatives could help, and could help all of us. So getting substance use training in basic training of professionals. Yes, it's a great idea. Some countries have done this. Portugal has done this, so this is a really good example. Some countries set staffing profile requirements for different types of service, and perhaps this could help. If we've got services without enough doctors or nurses or counsellors or key workers, setting the profile may help. Having staff qualifications or credentials or licenses to practice, that could really help. There's an example there. In Holland, professionals are required to be registered on the big registry. Germany's also got a good system there. There's some good international examples of national training centres that are multidisciplinary. There's some good examples of large treatment providers that have national training centres. Project Ombra in Spain is a good example of that. That's an NGO, but it's got a national training centre, and all staff are required to go there before they start work and then regularly for their CPD. Then there are good examples of regional multidisciplinary networks of different professionals to support different groups of professionals, and Austria is an example where you see some of those initiatives. In terms of some of the international drug treatment workforce issues, let's just flag the universal treatment curriculum. So these are international courses. Joanna talked about these. They're mainly developed by universities. They are available in different languages. They were developed to be face-to-face, but they're currently being modernized into an online format so they can be self-directed training and trainer-led courses. There are courses for practitioners, drug treatment practitioners and prevention and recovery practitioners. They are credentialed. They do provide qualifications that are internationally recognised, and universities and treatment providers can apply to deliver the courses. They're funded and developed by US State Department, but donor nations actually pay for these to be delivered to staff in low to middle income country. And I flagged there UTC basic courses, specialised courses and advanced courses. Please check these out on the ISSUP website. There's a list of the basic courses. There's 8 courses. There's a list of the advanced courses. There's another 13 courses. And the specialised courses include courses in terms of treatment for women. Those are the GROW courses. Courses for children and young people related treatment, the child courses, and then also recovery coach training, 2 courses. Okay, so in conclusion, my conclusions are that sustaining the capacity of quality in drug treatment systems is actually quite difficult, even in high income countries. And I think we need to play the long game and look at what we can do to embed those initiatives in countries. Even if there's an input of monies, what do we do to ensure those workforce initiatives and maintaining quality is enshrined in systems? In England, our systems have great strengths, but they've also got deficits, including a big lack of inpatient services at the moment. I don't think we meet international standards for workforce, particularly in terms of having qualified or credentialed drug and alcohol basic workers. Yet we've got more universities with drug and alcohol courses than almost anywhere else in the world. And our lack of qualified and competent core staff lets down our service users. So in England, workforce capacity is a serious issue. It does require a serious strategy and investment. So let's hope our government does develop that strategy and invest in the strategy. And let's hope that we make competence and qualifications a requirement by our funders and by our quality assurance mechanisms, particularly our care quality commissions. And that's not just the nurses and doctors, it's also psychologists and staff trained in psychosocial interventions, but also staff with lived experience. And we don't have to reinvent the wheel. We can all learn from the international initiatives, from ISSUP, and we can all share our knowledge and experience. Okay, so that's it from me. I'd like to stop my screen sharing there, if I may, Olivia. I hope you enjoyed that. And I'd like us now to move on, and I'd like to introduce our next speaker. Our next speaker is Ben Parker. Ben is a senior peer support worker for the National Health Service in London. So Ben, over to you.
Thank you, Annette. Thank you. Hi, welcome everyone. Yeah, so as Annette said, my name is Ben Parker. I am a senior peer support worker within the NHS and mainly in addictions. So for those of you, just to kind of give you a bit of a run through of what peer support is. So I am someone with lived experience of substance use, and you know, I've come through the treatment system myself. And now I'm actually working in it. So I think what I will do is I'll just start off with, you know, how it started, what I got into, and a bit about what I do now. So, you know, I think, you know, everyone knows about how people drinking drugs, so I don't need to give people a synopsis on, you know, how that went. But just to kind of give you a bit of background info, you know, I was one of those people who was, you know, in treatment yet time and time again, on a methadone script, in and out of prison, and so on and so forth. Towards the end of my using, you know, I did ask for help, and you know, I got the support that I needed. I went into a rehab, I got detoxed, and I came out. I started volunteering, and you know, on the way I met Annette, and I became, you know, a peer support worker at that time. And if I'm honest, I did not want to get into the drug and alcohol field, or, you know, work in the field, but I did, because I had a sense of, when I went into treatment, the counselors were also had lived experience, so I felt that maybe I do have something to offer, you know, other service users. Throughout that time, I worked as a peer support worker for 2 years, and mainly supporting people into treatment. So that meant the people who came through the door, sharing my experience, letting them know that, you know, that the nurses and the doctors who traditionally work in these services are not here to judge, they're here to support, and also bridge that gap between the service user and the professionals that work in the service. If I'm honest, I think I've done that quite well. But ultimately, what I realized is that my story alone could not help people. It can give them hope, and it can give them faith that one day they recover, but, you know, my story is not going to help, you know, get someone clean or off the substance. So what I then did, I went to work as a recovery worker for 6 years, and then I was the person actually supporting people through their actual treatment journeys, from the time they signed up, from the assessment, whether they were put on a methadone prescription, whether they were given an alcohol detox. So I was that person who supported them from the start to the finish. And what I kind of, what I suppose that what happened in that role is that the things that Annette has said started to happen. So the funding started to get cut, and, you know, there was a lot of agency staff coming in at that time, and so on and so forth. And I think for me, what happened was also I got demotivated with the job. So I moved on to where I am now, an actual senior peer support worker working within the NHS. So the job before wasn't with the NHS, it was with a private sector, voluntary sector, but now I'm working back within the NHS, as a senior peer support worker. Again, the side of treatment, so I work at the latter end of treatment, supporting people who are abstinent, and who want to remain abstinent. So, you know, going back to what Annette was referring to in regards to the workforce. Now, if I'm honest, I have experienced this myself, the lack of training, the lack of qualified staff, and if I hold my hand up, I am to one of those unqualified staff members. Don't get me wrong, I have a health and social care. I have pushed myself to do other vocational courses, but this wasn't something that was suggested to do. It was more that I wanted to do it. So now I'm on the other end of the spectrum, and now I am working with individuals that who are abstinent and who want to remain abstinent. I felt the need to actually, you know, go back to university and educate myself, because I actually felt that I was doing the individuals that I'm working with an injustice, basically giving them an intervention, which, yes, I know about because I have my own experience, but I did not have enough knowledge base. I've got my own experience, yes, but the theory and the theory behind certain topics, whether it's cognitive behavioral therapy or positive psychology, I didn't have I didn't have as much knowledge as I felt that I needed to support individuals. So for me, I've said that I want to go back to university to also to one, get my skills up and my knowledge up, and not that I don't know what I'm talking about, but feel confident and competent in what I'm talking about. And two, like what Annette said again in that review, like be a part of a body, because if I'm a part of a body, then I'm also accountable. And yeah, so, and also the treatment system in the UK has somewhat dwindled, but I feel that we've got far to go, but we can get there. It's a bit like Arsenal in the Premier League. They're not doing too well, but they'll get there in the end. So just to conclude on what's been said, and give my, I suppose, synopsis of the treatment system. It was good. It was amazing at the start when I was coming into treatment. Everything was kind of thrown at me. So people were asking me time and time again. Every time I came into treatment, people asked me, do I want to go into a detox? Do I want to go into a detox? And often I said no. And then after that, what happened was, what happened was I kind of just dismissed it, and I said no, until at the end I said, I do want to go into rehab and so on and so forth. But now people are not being offered this as much, and the main thing is it boils down to money, and then it's risk over need. So the person who is more risky is going to get into treatment rather than the person who is less risky. The person who is less risky may have, they may want it more, but the person who is more risky, because that person, has maybe has a loads of comorbidities, they will, be put into a detox before the other person. Also, I think that, staff, qualified staff, I feel that staff are not pushed enough by, whether it's line managers, whether it's supervisors, whether it's just staff in general, are not pushed to further their careers. And also what I've seen is, what I've seen and what I've witnessed is that every time you go to a different service, so there is a lot of agency staff, and every time you go to a different service, things are done differently. So there's no one systematic way that that drug and alcohol services work. In theory, they should, yes, but every service has a different way of doing things, which is not helpful for staff members who have come from one service to a different service, and now they have to, learn new systems and so on and so forth. Also, I feel that, people like myself, yes, 100%, I feel that there should be a curriculum that we work from. I do know that within the NHS Trust, we do have a curriculum. We do have a course which we work through, but it's not specific. So it's more an overview of peer support, because we have a lot of peer support workers who work in different settings, and it cannot be tailored to one setting. So we have peer support workers in mental health, we have peer support workers who are peer educators, we have peer support workers who are health trainers, we have peer support workers who do a range of different things. So I think for the trust, it's hard to kind of be specific within the curriculum that I follow. But on that, I think if anyone's got any questions to ask me, please put it in the chat, and I will be happy to ask them a bit later on. And yeah, that's it from me. And thank you for having me, Annette.
Ben, thank you so much for that. Thank you for sharing your experience and your wisdom and knowledge. For everybody that's listening, Ben's helped many, many people, and I'm sure we'll continue to do so. So great job. So thank you. And I can't believe you got a football reference in there. That's so funny. That's so funny. Thank you so much. Okay, that's great. Thanks. Okay, I'd like now to introduce our next speaker. Our next speaker is Professor Carmel Clancy. Carmel is an academic dean at the University of Middlesex. I've got great pleasure in working with her there, and she's also the president of IntNSA, the International Nurses Society on Addictions, and she's going to be talking with us about the role of nurses in addictions. And we were having a few internet issues this morning, so hopefully it's resolved, and hopefully we'll be able to hear you really well. So over to you, Clancy. Carmel,
thank you. Thank you, Annette. Can you hear me?
Yeah,
can
great.
you hear me?
Yes,
great.
Thank you.
Okay, perfect. And my apologies. You're not going to get me on camera, but maybe that's a blessing. And hopefully you've got audio and it's going to come through loud and clear. Like Ben and previous speakers, just want to thank obviously yourself for inviting me to speak on this particular area, and also to ISSUP for the wonderful work that they're doing around all of this and connecting us. I believe, I think last you told me there was about 800 people signed up to this webinar, which is absolutely amazing. So even if we have something close to that, I'm sure it'll be of great benefit to us all. So thank you for the opportunity. I'm going to give you hopefully a whistle-stop tour, so to speak, in or on the role of nurses in substance use disorder treatment. It is interesting, and you might ask yourself, well, why were nurses singled out, particularly as opposed to any other discipline that works or any other worker that works within the workforce, given we truly know, and as I think previous speakers have just really nicely outlined to us, everybody is needed in this field, and there's plenty of sky for us all to fly. And indeed, we all recognise that we all do much, much better when we're in a team and in a multidisciplinary team and a multi-agency approach. However, I think that maybe, and we can get to that if we get a chance for Q&As, one of the reasons the role of nurses was picked up particularly is that we do know that nurses are probably, outside of the generic drug and alcohol worker role, the biggest role probably in the drug and alcohol field, certainly in my experience in the UK, which is where I'm really speaking from, but in my role also as president of INSA, which is the International Nurses Society in Addictions, we're aware that nurses very much are at the forefront of treatment and care, and either directly but most likely indirectly come across substance use disorder, perhaps more than any other discipline, I would hasten to guess. So what I'm going to do is ask my lovely assistant Olivia to take us to the next slide and perhaps just start off. And I don't know if people are a fan of Banksy, but I just love this. This, of course, was an image that Banksy posted in response to COVID and the pandemic, and he's put down all of the other superheroes, and the nurse becomes the new superhero. And as a nurse, you can imagine we were very grateful to see that kind of image around the world, and it certainly seems to have been echoed everywhere. But there is, and I think the ICN, if you're not aware, is the International Congress of Nurses, does speak to the fact that we, you know, as a nursing group or as a nursing discipline, we are everywhere, and we have a long, long history of working at the forefront of caring, particularly for vulnerable and disempowered. And nurses will have either witnessed or seen incredible, you know, sort of incredible issues, but also made huge sacrifices for the betterment of health. So nurses care really for everybody. I hope you would agree. And so it's for this reason that the role of the nurse, I think, globally is extremely important to look at as to how we might mobilize. If we have the next slide. But we can't, at this point, ignore the fact that we've had a couple of extraordinary years. And again, we've had the year of the nurse in 2020, and what a year that was that just coincided, of course, with the pandemic when everything closed down. But I would like to speak, in next slide, that there are really two parallel pandemics, and we don't often actually refer to substance use disorder as a pandemic. But actually, if you really look at the criteria, I hasten to suggest that we probably meet some of that in the broad sense, or the broad strokes, in that it is so ubiquitous, and there are no boundaries, no social classes, no area of the world that I think I've ever come across where substance use doesn't feature, be that through alcohol or indeed illicit, and so forth. But this just kind of gives you a sense of what we are facing, in that we have the substance use disorder and all of the challenges that exist within that particular area of work. And then, of course, we had with our pandemic and COVID, which unfortunately doesn't seem to be going away as quickly as we would like. And certainly people are saying there will be more on the horizon with the way our world is working at the moment, but that there is, you know, sort of huge additional challenges that have been happening globally. And nursing and nursing role, indeed, all of our roles have been in some respects influenced. And so you can see drug supply interrupted, deferred school and travel, social distancing, and so forth. So really, we've ended up with the worst of both cases combining and colliding for our particular client group. And more specifically now, more globally, because we know that there is a tsunami of mental health about to hit as a consequence of COVID. And we do know, unfortunately, that the go-to, perhaps, way of responding and dealing with crisis and anxiety is through the use of drugs and alcohol. So ultimately, we are looking at a huge burden of disease coming down. So therefore, role of everybody, including nurses, is going to be important. Question is, are we ready? So this is where perhaps we need to be thinking about what is that role. So next slide, please, Olivia. Thank you. So if you can see here, there was a paper and the reference is on. It's an open access paper. You may be interested, but let us not forget or underestimate that the workforce is required and the treatment needs. And if we look to the next slide, just very briefly, and this is just flashing it in front of you, it's a little busy, but I understand this is being recorded and hopefully you can interrogate or indeed go to the open access document yourself. But it shows you really the breadth and the depth of the morbidity and the burden of substance use. And it's not, as you might appreciate, to do with just the specialised area. So we really is, whilst we obviously do need a very specialist area at one end of the spectrum to look after people who are very, very burdened and compromised by addiction or the dependency end of the spectrum. But unfortunately, right down the other end, even at the beginning part, we know that the burden of disease influences right across and is different for men and for women. And this is, I think, a very lovely, very in-your-face sort of demonstration of the ubiquitous, and as I say, no bars held as to who gets impacted and affected. And of course, this is directly for the individuals, notwithstanding their loved ones, their family, their friends, and their wider community, who then have to come in and support and care for them. So no question we have an issue. Where is our workforce and how can we do something about this in terms of roles? So moving on, in this one, you will see that I believe, and I think my fellow nurses would agree, that we have a workforce waiting to be mobilised. So if you look at the numbers, and for me, I kind of get a little giddy on these numbers, that even if we only partially got these numbers mobilised, look at the numbers we're talking about, who would be educated or at least able to understand and have an awareness of drug and alcohol use and problematic substance use. Even if we could get a marginal percentage engaged in asking screening questions, how many would we actually prevent from furthering down that spectrum of burden of disease? There's 27.9 million nurses globally, as it's estimated, captured through data that is picked up in the State of the World's Nursing reports, which is reflective of 191 countries. That is phenomenal. Nearly 28 million nurses ready, recognised, working very much in the field. We know that they're the major contributor, irrespective of country, but we also know that most individuals with substance use problems are not seen by the specialists, but in general practice. So hospitals, accident and emergency, and in more generic locations, social services, indeed schools and prisons. So all settings where nurses work and offer care. So next slide, please. But critically, some of the issues why nurses, and I would have to say all professions in my view, because I take and have been an educationalist across the spectrum, from doctors to nurses to generic workers. And I would say that the issue that seems to be in play often why people aren't mobilised, particularly the professions, are three sort of interchanging locks. One is role support, role adequacy, and role legitimacy. So often the role legitimacy is that many people feel that it's not their job, it's not their role. You'll often hear nurses say, well, the doctor will ask that, or the doctor will say, well, the social worker will ask that, and so forth. You get the picture. So they don't feel it's legitimate because nobody's actually telling them that it is their role and that they have a part to play. Equally, they don't feel adequate, and you've heard multiple times, I think, already in this webinar, the training and the preparation. People are not being trained despite these courses, and that is a legacy that's been going on for 20 years at least, and we barely moved the dial in terms of preparation and training. I'll come back to that in a moment. And of course, if you don't feel that you're legitimate in your role, or you don't feel you have the skills and knowledge, and there aren't actually other people around to support you, which is the role support. And we've just heard about the decimation of services in the UK, but we know that there are very, very few services on the ground in many other countries. If that role support of specialists is also not there, so that the genericist could ring up the specialist and talk through a case, then equally that means it can fall over. So all of these three components work beautifully together, and if they're in play, often will allow and assist and facilitate mobilisation. But that's where we are at the moment in terms of some of the challenges. Next slides, please, Olivia. So here you will see in the next slide, I think I've lost, there she is, that success needs preparation. So combating drug and alcohol misuse depends on a skilled and competent workforce. Clinicians' expertise and experience are key components to evidence-based practice and translation. That is well accepted, and I think Annette said it beautifully in her presentation. And the association between level of training and innovation adopted is well established. So we know that we need, in terms of quality, if we're going to have quality services, it all starts really at the preparation and the educational end, although it's not the only factor. Next slide, please. In relation to just giving you a sense of that, and as I say, we've barely moved the dial. If I just even take the kind of classic, disciplines, doctors, nurses, and social workers, who you would believe should be trained, in substance use related issues, basic, not even advanced. You can see here on the screen the amount of hours from various studies, and it is phenomenal. If you think that doctors invariably, depending on the country, can have anything from a minimum of 5 or 6 years training up to and including getting to their expert consultant level up to 10 years, they get 3 to 15 hours over that period. Of actually related content in their undergraduate. In terms of nurses, it's anywhere between 5 and 11, and most nurses in most countries do approximately 3 years of training. And social workers, again, 8 to 11, and they also do between 3 and 4 years of undergraduate training. So clearly we're doing something wrong, we're missing it, we're failing, I think, our future workforce, and really the gauntlet is thrown down. How do we address that? Particularly me as a faculty member, we need to get something right, and we're not doing it. And I'm very pleased to see Dame Carol Black's report, because she speaks to this issue quite clearly, and I'm hoping, particularly from the UK, we're going to be able to leverage that as we move forward. So next slide, please. So this is despite efforts, and so it's a very busy slide, and I'm not going to go through it, but I know, as I say, this is being recorded and will be made available. But each of these particular areas are linked, and there's a link to the internet where you will be able to find lots and lots of work that's already been done, largely, as you can see, in the USA, Canada, and Australasia and England, who have set out standards around roles, sometimes curriculum, very specialized curriculum. And it may just be, for those of you who have yet to do this within your respective countries, a good starting position for you to look at what's already been in play and what's already been happening around the world. And even despite all of these scopes and standards, curriculums being developed, we're still falling way behind, and I believe, sort of have still lots to do, even in the countries that we're mentioning, and my colleagues who are experts around this would probably agree with me. Next slide, please. So just to give you an idea, and forgive that there's a slight little overlap on the slide here, but what I wanted to try and talk about is that there is clearly, if you look to the left of the picture in front of you, the illustration, we know that not everybody needs treatment or indeed needs to be in treatment, because there is a spectrum of use, from little or no use through to harmful use to dependent use, and then people who really do need specialists. But overall, if you look at the role that the nurse may play, the addiction nurse really will only start and should only really be required from the dependent and maybe more advanced comorbidity and complex issues. The generalist nurse, and forgive me for using the term generalist because I know most nurses would feel that they're expert in their respective areas, but by generalist I mean people who are not working specifically in the drug and alcohol field. For me, the large majority of the role can happen actually by my colleagues working in the broader health arenas. And I actually use pretty much a statement which is every nurse is an addictions nurse, but I'm obviously a little bit biased. Perhaps if we move forward, Olivia. So in the next slide, you'll see, taking that into consideration, that I think that there is generalist and addiction nurses. If I look just at the role of addiction nurses in the UK, and here is just a sort of an illustration, nurses have been, and we can only find it from a published point of view, that back to 1955, that nurses were part of treatment teams. I suspect that back as far as Florence Nightingale, you know, people were drinking and probably using substances, and nurses were certainly part of the picture of trying to talk them through that. But formally, in terms of trying to capture literature, it seems that we have some evidence very clearly talking about a nursing role specifically within treatment, and that goes back in the UK at least to 1955. And then you can see sort of the pattern in the development of the nursing role, which has become more advanced as the years have gone forward, including obviously education and the changing role of nurses, to now at this point having a consultant or non-medical prescribing. So nurses have much more advanced skills and are actually prescribing, particularly in the UK and the US and in Australia, not necessarily everywhere, but they are looking at that in terms of advanced practice. I suppose the question now going forward into sort of into the 2021-22 is what might be the next steps, and we are certainly exploring that at the international level globally in INSA, and we're actually working in partnership with ISSUP and the network of nurses there to look at global certification, and perhaps at a next webinar we'll be able to come back and tell you on that. If we could go to the next slide, please. And so here is specifically, I just wanted to touch on, to give you a flavour of what we think is the role. This is a piece of work I did with some colleagues through Public Health England, and it was actually on the back of a series of other helpful documents around the role of doctors and psychologists, and actually speaks to what Annette spoke at the beginning. There was a growing concern actually about that the nurses, doctors, psychologists were starting to lose footing and a hold on treatment around addiction, and people were losing an understanding of the value of those particular roles. And so the PHE actually asked us to do a specific document to really spell out to commissioners what it is that nurses can bring to the table in terms of treatment. So I'll quickly go through that if I may, and you will see just very briefly, we talked about 4 domains. We believe that the nursing role follows over 4, particularly clinical, and I'll speak to that. All of these just very highlights at the moment. Leadership, of course, and clearly have leadership training, teaching in that we teach not only our peers but also our other colleagues, but we also teach patients and their family and their carers. And then, of course, a big issue which we're talking about today is quality improvement and audit, and nurses certainly have expertise and skills in that. So if we quickly look at each domain, you'll see that in the clinical, on the next slide, we picked out the following, and this document is available and freely accessible. We talk about that the nurse can be involved in a variety of these particular areas, and specifically triage, risk assessment, safeguarding, and so forth, including vaccinations, which of course is very relevant at the moment, but of course including mental health checks, and down to wound dressing, which of course unfortunately can be a feature of many of our clients, including, and then of course very much health advocacy. If we move to the next, in terms of quality improvement, nurses are very much at the forefront of developing and leading on quality governance, clinical audit, service development, data monitoring, and of course engaging in public health and clinical research, and would be members of various committees. Next would be, I'm just going to see because I think it's leadership, leading and managing teams, clinical supervision, reflective practice, and advising, of course, commissioners and policymakers right up to government level. And then the final one in teaching kind of is what you would expect. It's continuous professional development, developing training to non-specialists, teaching on undergraduate, postgrad, and of course, mentoring of our students. And this goes to the point, really, if we are not in these places, in treatment centres, and providing this sort of input, who are the next teachers of the next generation of workforce? And I put that to any discipline. If you can see yourself, where's the next generation of workforce? Next slide, and I'm just coming up to a conclusion. So I would just like to say that ultimately we have the key message: a competent workforce is directly linked to better outcomes and evidence-based practice. Training and education are key components and a significant part of an overall response framework. And next, please. And then what next? So these are just some ideas of what we're trying to think about. Ultimately, in terms of roles of nurses, if we're going to mobilize nurses and engage nurses, we start, and we will have to continue, unfortunately at the moment, continue to fight stigma and raise awareness. We need to be focusing on the recovery. A lot of people think that, you know, substance misuse, yes, it's a chronic relapsing condition, but people do recover, and we need to have recovery language, and we need to be positive because we know that that influences outcomes. And we need to be working with emerging groups, particularly in our role as nurses, particularly the older drug user, and there's a whole spectrum of work that's emerging around that, which is really quite exciting. Developing and strengthening nursing expertise, explicitly nursing interventions, education. My own bugbear is pre-qualifying. We need to get in at the level of pre-qualifying to let our particularly around the legitimacy bit I told you earlier, if we don't let nurses know that this is a legitimate part of their work, they're not going to engage and maybe not go on to develop further skill. And that to me is where we can capture people the minute they cross over the threshold into their training and they are being acculturated and inducted into the nursing profession. They need to know that substance use is part of their portfolio. And then, of course, we do need certification recognition of role, because standards will dictate sure that we hit that. And of course, treatment services need to be getting people with the right certifications. And then we need to design scope standards for nursing addiction globally. This is the work that we're hoping to start developing, both certification and scope and standards with our partner INL and ISSUP. Developing clear pathways will be very important, because retaining the good staff is really good. Retaining your talent, it also influences quality in relation to delivery of practice. And then we do need networking and collaboration, both nurse to nurse, but nurse to other disciplines. And as I say, we're very excited with our partnership between ISSUP and ourselves in terms of what we might be able to do together more collectively in that mobilization of that nearly 27 million nurses. And then last slide, if we may. What I'd like to do, and I think Olivia has it keyed up, is play to you a very 1 minute something little video about the role of nurses, and we kind of go with the strapline, addiction nurses save lives. I hope you enjoy it. Very happy to take questions, and thank you for listening. Thank you, Olivia, and thank you everybody for the time. Thank you, Annette. Back to you.
Carmel, thank you very much for that. Sorry, I've got an ice cream van going off in the background. I don't know if you can hear that. Thank you very much for that comprehensive overview of the role of nurses. There's lots of reference material there for people to go and check out. So if you didn't catch it as Carmel was speaking, please go to the recording of this, and we'll consider doing webinars on each of the professional groups to go into these issues in a bit more depth. I'm mindful of time, team, and I know that we're running over slightly. We did start late and we had a few techie issues, but it's my great pleasure and privilege to introduce our final two speakers. So these are our colleagues from Scotland, which of course is in the north of the UK, and our speakers are Angel Shek. Angel is a senior policy officer, Drugs Policy Division, Health Improvement Team in the Scottish Government, and Tracey Clusker, who is a nurse by background, substance team leader, and a non-medical prescriber at NHS Lothian in Scotland. And they're going to talk a little bit about workforce development initiatives in Scotland, including the mapping of the workforce that's happening at the moment, and then also the challenge of rolling out some new standards on medication-assisted treatment. So Angel, Tracey, over to you guys.
Thanks, Annette. Hopefully you hear me fine. Conscious of the time and some of the key themes that I will be touching on, Annette yourself already spoke about at the start, so I won't go into too much depth on that. But hopefully the similarities and approaches is a good thing. If we can go to the next slide. So this is just a definition of what we regard as the workforce and development here. I won't read into it, you can read that probably afterwards. And can we go on to the next slide, please? So some of the workforce challenges that we know so far in Scotland is just outlined here on this slide. We know that widely because of this area that staff retention is an issue and the rate of burnout is high. Staff are taking on too many caseloads at a time and causing a strain in the workforce to deliver. We also know that there is recruitment difficulties in securing some posts, and some posts are not being filled in a long time. This seems to be more of an issue within more rural areas. Touching on the difficulty in securing some of the posts, there is an issue with securing specialists such as psych. However, we do know that there is a shortage of these, in the health industry as a whole. There is also gaps in training that need to be identified and addressed, and the implementation of this training in practice also needs looking into. And we know overall stigma that is present and the stigma that is experienced in the workforce and those as well with lived in. So next slide, please. So what are we doing about these challenges? So as of this month, we are beginning to plan a mapping exercise to scope the current workforce. The workforce planning is a crucial element of delivering the commitments and the ambitions of Scotland's national mission to improve and save lives. And this exercise will inform a long-term plan and supporting workforce strategy that will seek to deliver a whole family approach, address workforce shortages, strengthen the workforce and service planning at all levels of the system and support new ways of working. So as you can see here on this slide, there's just a summary of what our mapping exercise looks like. So we'll start with the capacity mapping to find what the current workforce looks like in terms of numbers. We'll then start to scope out the current recruitment processes and what training there is available. This will then lead us on to more detailed analysis on pathways into the workforce, the stigma that's present and how we overcome this barrier. We then also look into working collaboratively with other parts of government to integrate services such as mental health and substance use and identify the gaps in training here as well. Next slide, please. So this is all in line of what is set out in Scotland's Rights, Respect and Recovery strategy to improve health by preventing and reducing alcohol and drug use and harm and related deaths. I won't read into these on this slide either, but some of these lines I've taken from the strategy, and we will look at these to guide our workforce development and commitments. So I'll now pass you on to my colleague Tracey, who will give you an overview of the implementation of the medically assisted standards from a workforce perspective.
Thank you. Next slide, please. So I'm just going to talk briefly about one of the strategies in response to the drug deaths in Scotland, which is the medication assisted treatment standards, and this MAT is used to refer to the use of medication such as opioids together with any psychological and social support in the treatment of care of individuals who experience problems with drug use. This is a response to the high drug death figures we do have in the Scottish context, and we have an ambitious target to implement these targets by April 2022, so we're working very intimately with all services across Scotland. Next slide, please. So just very briefly, the MAT standards came from a drug deaths task force in Scotland that was set up in response to drug death figures, and the consultant who led this work was Dr. Duncan McCormack, who's Public Health Scotland, and myself as clinical lead, and we also have support from Public Health Scotland, Eleanor Dickey, and programme support from the Scottish Government. Next slide, please. So in terms of the implementation of the standards, we did start out, there wasn't time really to look at the workforce planning as in its infancy, but we have to have a response to the current treatment within Scotland and how we adapt that to reduce deaths in our country. So we used a diffusion of innovation. So prior to the standards being published in May this year, we started working with all the alcohol and drug partnerships in Scotland and clinical leads. So that would be the commissioners, the clinical staff, third sector and recovery communities, to try and get early innovators who were keen to try out the standards. And originally we looked to have around 5 test of change projects using quality improvement methodology, but we did actually have an appetite from areas across Scotland, so we were using the staff that were highly motivated to try and diffuse that innovation, and we now have over 20 projects with a view to scaling up all across Scotland. Next slide, please. So why is this important? In 2019, 1,254 people lost their life to drug-related death. In 2020 figures in Scotland, that increased to 1,339, so that was an increase of 5%, so we have to have an emergency strategy. We do have a real issue in Scotland with polydrug use, so whilst opiates are implicated, we do have an issue around benzodiazepines, gabapentin, stimulant and alcohol. Next slide, please. So the standards are in relation. We published 10 standards. I won't go through every single standard, but I must focus this is not just based on a medical model. You'll see this is around people having an option to start treatment on the same day. So what we want to do in Scotland, we have low numbers of people in a structured treatment service. We want to aim to have that much higher. We know that treatment is protective in terms of drug harms, quality of life indicators and drug death. So this is around psychological support, it's around housing, it's around welfare support, mental health support, harm reduction and the other physical comorbidities that people may experience as a drug harm. So in terms of the workforce, it is very varied and not just within the substance use services that are NHS based, so we have to engage and bring together pathways so that the aim of the standards is that the person is centred to what their treatment is, and the services will work around that person. The standards are actually in line with the vision in Scotland for NHS Scotland that by 2025 anyone providing health and social care will take what we call a realistic medicine approach, and that means that that person is in partnership with whoever they are seeing within the health and social care system, and that they are centred and pivotal to all decisions that are made about their treatment. The aim of the standards was to provide consistent delivery and that people could make informed choice, that there'd be family involvement, and it would strengthen accountability and leadership in this field. Within the publication of the standards, we do have a chapter on what it means for people who use services, what the standards should mean for families or nominated persons, and what it should mean for staff who are working in the substance use field. In terms of staff, we are very clearly stating that staff have to be supported to offer treatment, and if they're not trained to the level they are for the treatment that's been requested, that there needs to be a clear pathway to the correct person. That there's governance structures in place to enable safe, for instance, prescribing, or to enable that staff are supported, and that they have received regular supervision. We also speak very clearly about leadership and governance. This is critical to ensuring safe, person-centred, equitable service, and we do have a framework to look at how we monitor that in terms of, do people have policies, procedures, regular supervision documents, and training packages for staff. Next slide, please. So within the team that we are working with, we are offering direct support for small and unfunded projects in terms of the implementation, and what we've had to be is be really pragmatic and innovative in terms of, you know, that workforce or people are doing projects who haven't yet recruited to posts. So some of that support's been around some of the projects in terms of psychological support. For Standard 6, we have been working with psychologists who are doing training packages to upskill other third sector staff as well as nursing staff to be trained in psychological intervention. So we are funding some projects, and that's a way of trying to meet that standard using the workforce we have at present. We know we have a shortage of psychologists in terms of rapid access to, for instance, opiate substitute prescribing such as buprenorphine or methadone. We are looking at, we've been working with projects to look at the more use of non-medical prescribing, advanced nurse practitioners. We are using pharmacy models, and the pharmacy models are trying to do more outreach to try and assertively work with people in the communities they're in. We also have a project around young people, and that's looking at the child and adolescent mental health nurses, working with third sector to upskill, offer support and supervision to provide that early intervention to reduce harms. We also are looking at programme managers, so that would be to a programme manager across health boards to provide that consistency to ensure that there is that equitable treatment. We are going to be working with areas for a large scale up of the standards. And what we have done in terms of mapping the workforce, we have written to all, there is 31 alcohol and drug partnerships, that's commissioning body in Scotland. We have written to every one of them asking them to give us what they would need in terms of staffing, in terms of training, in terms of policies, procedures, in order to scale up the standards by April 2022. So we will be working and engaging with them to look at innovative models, and that was mentioned earlier, that people are working to the level they should be. So some of the models are utilising prescribers, non-medical prescribers, but we can have qualified third sector staff offering that psychological wraparound support, and we are looking to benchmark that and collate it, and any learning or any new ways of working to share that across Scotland, and that's been very successful, sharing innovation and learning from quality improvement projects. Next slide, please. So just really very quickly, our outputs as a team is to inform success in the benchmarking and really to look at that national business case for sustainable care and treatment. What would that actually look like in Scotland in terms of what does a staff team look like to provide that good quality treatment for people, and what would that cost be? We want to provide continuous quality improvement, progress monitoring and participation, and we want to improve access as an immediate goal for us is to get more people into treatment, a quality treatment, and we will be, as I say, looking at early adopter sites, and we want to scale up the standards by April 2022 across Scotland. Next slide, please. So just to say really, thank you for inviting myself and Angel on. Happy to take questions about the standards, but we do know it's a challenge in Scotland, and we are working in a very intimate way with all stakeholders in this field, including people with lived experience and family members. So thank you.
Hi there, Angel and Tracey. Thank you for those really informative presentations. So Angel, your Scottish Government presentation had some very similar themes to England. It's very interesting, and it'll be fascinating to see how your mapping goes and what you find when you get into the detail of that. Tracey, thank you for your detailed plans on the rollout of opioid medication assisted treatment in Scotland. Scotland clearly has challenges over drug-related deaths, but these are really concrete plans to try and tackle some of those issues that should be absolutely commended. And I note that whatever you do is in consultation with the local partnerships, which is great. And I think it's also interesting that you mentioned your strategy recognises that not everybody is going to be ready immediately. So you've got the early adopters and you've got people that will come on later. So you've got this staggered approach, which is very realistic, and then some very hard and challenging targets coming down the line. So thank you for both of those presentations. That's great. We're at 2:05. I've got some questions in front of me. I'd just actually quite like to ask the panel members to flick on their cameras if you've got them. I know Carmel and Angel can't do this at the moment, but hopefully we've still got both of you on the phone. The first thing to say from the Q&A that's coming through is that we got some very positive feedback about all of the presentations, which is excellent. So well done and thank you to everyone. We've got some detailed questions that will then refer to the quality and treatment site. So we'll put all of the questions up there and then with some of the answers. So some detailed ones such as, can intervention-based therapy reduce relapse chances? Is recovery orientated treatment based upon follow-up sessions, etc., etc. But a couple specifically for the panelists, and I'm going to call on Ben and Carmel if she's still there. Ben, I got a question directly to you, which was, how did you overcome stigma related to using substances, which I thought was a really interesting question to be posed, actually. So I don't know if you'd like to make some comment in relation to that.
Yeah, no, that's fine. That's perfectly fine. Can you hear me well?
Yes.
Yeah, because I've taken my headphones off. So how did I overcome stigma? I think me, myself, the stigma that I had of myself, firstly was combated by seeing people who had fully recovered. Secondly, I feel that me being someone with visible recovery is kind of dismissing that stigma that someone with an addict can't change, a leopard can't change its spots, that every person who uses a substance is a criminal, they'll never, all of those kind of phrases that I heard. What I do, I am that visible person to say, actually, someone can make something of their life. And just to kind of give you guys a brief synopsis, before I came into treatment, I was homeless on the street. Now I'm here in my own property with a wife and a kid. So, and that's what I show people, even family members. So that's the way I kind of, dismiss stigma within my life and within the services that I work in.
Ben, thank you for that insight, and really struck me that you said that you had to tackle the self-stigma as well as deal with the external stigma. I thought that was a really interesting comment. And I think that people with lived experience that work in treatment services are very brave, actually, because I think you're dealing with a whole bunch of stuff internally, but then also this rubbish that we sometimes get from other people as well that you don't deserve, and we need to tackle all of the time, really. Carmel, are you still with us?
I am. Can you hear me?
Yes, we can hear you. This is an interesting question that came through that I thought might be really kind of interesting. for you, which is, and it's a question about what professional qualifications could commissioners or funders in international language specify. I wonder if you have any comments in relation to that question.
Oh, that's a great question.
Great question.
I'm assuming in relation to nursing. I mean, you see, when you're,
Wider.
you know, or indeed wider. I mean, I think, I mean, at the end of the day, one of the challenges that we have from a global perspective, of course, is that nursing and and people may not be aware of that, but the actual title of nurse is not protected in many countries. So I'll just talk from a nursing perspective at the moment. It may translate to other professions, but there is no protection over the title. So even when you're employing somebody who is a nurse, you can't necessarily assume that they have actually got a certified qualification in certain countries globally. So first and foremost, I think, you know, kind of that speaks to the complexity of what we're talking about when we're talking about trying to approach this either globally or even regionally, if we take the WHO regions and try not to be too expansive or ambitious. But there are significant issues around certification, even then within nursing, where there are certification courses. So they range from, you know, people taking nursing qualification at the level of a high school diploma, right up into sort of master's, PhD level. So again speaks to the complexity. So when you say what might be the minimum certification, I actually don't know if there is a good enough answer in the short space that we have, and I wouldn't want to get into the details, but it's certainly, it's a great question. I will tell you that in working with INSA, we have a scope of standards and practice. We do actually have a certification called the CARN, Certification in Addiction, for a registered nurse and for a registered nurse advanced. So there is a curriculum, there is a certification that is accredited and that already exists. They have it also in I believe in Australia. And so there are some examples that you could speak to look at that certification process. We personally are looking now globally with our colleagues in INL and perhaps also ICUDDR, which is the university network in drug demand reduction, part of the ISSUP family, and with the ISSUP family directly. And we're looking to put together a group at the moment to look at the whole question of certification. And it may well be that we start at, you know, sort of lower levels right up into advanced levels. So watch this space, because we're going to start to get into it. But there is nothing that I could say specifically other than the CARN and the CARN AP around addiction nursing that might give you some hints.
Okay, Carmel, that's a great answer. Thank you very much indeed. And we do have people asking, how does one join IntNSA? So perhaps you can, we can put that on the Quality and Treatment website as well, but perhaps we can ask ISSUP to share that information as well.
And, if I may say, Annette, sorry, and it is a bit of a plug for IntNSA, but if people are interested in developing a chapter in their country and it doesn't exist already, we would love to have that conversation with you.
Excellent, that's great. So there's a real shout out for people. If you want to have a chapter for nurses, an IntNSA chapter for nurses, that's great. I'd actually quite like to ask Tracey and Angel about that question again, about what qualifications do you think funders and commissioners should specify? Wider than nurses as well. Have you got any comments in relation to that question?
Do you want me to go first, Angel? Yeah, I guess we do, as part of workforce development, there are some, you know, we have a national body, the Scottish Drugs Forum, who do provide a great deal of training online, not just to, and they're an accredited training centre, so they can offer training in terms of harm reduction, unsafe use of benzodiazepines, that help people understand the role of OST, and they do quite a bit of training actually and around take home naloxone. So they're a national body that can offer that training. So I suppose it's firming it up and actually as part of an induction for staff or continuance, in some ways of continuous development. You know, that could be something that a commissioner funds and said we want every member of staff to undertake that. We also have a Scottish Recovery Consortium, so that would be, they're doing a lot of training around advocacy, around people, the use of people and skilling up people who have lived experience to give people the right skills to go into that workforce. So again, you know, they provide, and they can offer training. And we have another national body, Reach Advocacy, who train people and do accredited training on rights-based, human rights-based advocacy. So we could be asking commissioners, you know, in terms of third sector and nursing, because I recently went on the training for Reach Advocacy to look at human rights-based treatment and people's human rights in terms of their access to healthcare. And actually, as a nurse, it was quite a bit of learning for me. So I think actually some nursing staff, we can't assume know all the relevant information that they could. So I think there could be a package as an induction and continuous improvement as part of workforce development. So we definitely have some very good assets in Scotland that I think we could firm up and perhaps use, and I would imagine there'd be a willingness to do so. I don't know if you want to comment, Angel, from the Scottish Government point of view. I'm thinking more from Matt and the teams that we've been involved with.
Hi, Angel. I'm not sure we've still got you there. I think we may have lost her. Okay, all right. But thank you. That's a great answer, Tracey. Thank you very much. Well, let me just take a couple more questions. I'll read them out. It's a very interesting one, which is, if there's more universities with drugs and alcohol courses in the UK, why haven't we got? What do we attribute the lack of qualified and competent core staff to? Great question. Is it talent acquisition? Hard work not commensurate with compensation package? Or do they want to go and work elsewhere? Not in the treatment centres. I'm going to start this one off, and then I'm going to hand it ask who from the panel wants to answer this. In my perception of the courses in the UK that are related to drugs and alcohol is that many of them are not vocational. They're kind of academic, studying drugs and alcohol. There seems to be a real appetite for studying various aspects in terms of the drugs and alcohol phenomena. So they're not necessarily courses that will result in somebody being a practitioner. So they're not a vocational course, if you like. But it's a great question. And I wonder if any of the panel would also like to make a comment on that.
It's a great question. Because it's almost like going back to your analogy, Annette, of, you know, we got the gold medal and we still seem to have lost. I think it's a really good. I think you're right, though. I think that the question that a lot of the master's courses are very theoretical, and that there is very little of the courses where there's an internship. Where people can actually go into the practice areas and work alongside staff and patients and clients. And I think that's probably a trick we've missed in terms of reflecting back on the training courses that we had, because it's really through, for me at least anyway, vicarious learning. And I think even though I'm, you know, sort of done and developed a master's in dual diagnosis without necessarily having any formal training in addiction myself, so please forgive me, but actually I learned on the job, and I learned through my colleagues and with my clients, and I learned through talking with them and hearing from them about what was going on and being kept up to date. And it was through the expertise of my colleagues who had been flying perhaps longer than I had that I watched and learned at their knees, so to speak. So there's something about, I think, if I was recommending, particularly anybody's thinking of setting up courses, please include internship and make sure that there is an application aspect to whatever the training is, because it is going to be through the wisdom of our clients, who are the best teachers in my view, alongside the experts who have the training and have been doing flying longer than us, that you're going to really learn at their needs. So I think it's something to do with that personally.
That's great and very insightful. Anybody else like to comment, guys?
No, I'll just comment. I'll just echo what Carmel said. I think for me, when I was doing my DANUS units, I was actually working in the field. So I can reference, you know, what I was kind of learning theoretically, because and also like Carmel, you said you learn from the service users, but I think in my head, I thought that I knew everything about addictions because, yeah, I am someone who's lived it. But coming into and working in services, I actually found out there was a lot I didn't know. I thought I was the expert, but you know, being a part of those MDT meetings and being, you know, around consultants, psychiatrists, you know, nurses, and so on and so forth, I learned a wealth of knowledge that, you know, I can now actually go out and, you know, educate people myself. So I think, yeah, a bit of both definitely is the way forward.
Thank you for that, Ben. Great comments there. Great comments. I'm mindful of time. We've actually still got more than 300 people with us, would you believe? Which is amazing considering that we're 20 minutes past 2. Let me just read out a couple of more questions. And so we've got a question on what's the role of medical laboratory science on this topic. Interesting question. We'll answer that on the Quality and Treatment website. Interesting one here in terms of what's the association between staff qualification and outcome, particularly for opioid and heroin users. I think that's a really interesting one to answer in the context of the US, actually, and their very escalating opioid problem and the role of general doctors that are not trained in addiction. I think that's a really interesting one to think about. We'll come back and answer that on the website, if that's okay.
If I may interject, Annette,
Please.
I think you may also agree that it's attached to the economy and finance and being paid for prescriptions and private care.
Absolutely, absolutely. So it's a complicated one in relation to that as well. No, definitely. And I think that there is some evidence from some of the American research in terms of the valuable role of multidisciplinary teams, qualified teams, in terms of opioid treatment, etc. We've also got a couple of questions on supply and drug trends that, again, I'll park and I'll put it on the Quality in Treatment website, if that's okay. What I'd like to do is round us up, if I may, if that's okay with everybody. Firstly, I'd like to thank the wonderful team at ISSUP for hosting us. Joanna, thank you for your great intro. Olivia, that's great. And the whole team there, thank you for hosting us and making this happen. Thank you to our wonderful panel of speakers and your insights into quality and the workforce. They were all extremely valuable. And then last not least, thank you to everybody that tuned in to listen to the website. If you've got more ideas as to what you'd like from the Quality and Treatment Network in terms of webinars, please put suggestions in there or email me direct. Joanna can give out my email address. And thank you very much for participating, for listening, and we hope that the webinar was valuable to you. So thank you very much indeed.